السلام عليكم ورحمة الله. أنا محمد البنهاوي، أخصائي الأنف وأذن وأدمن في إيجيبشن ENT فورم. كل سنة وانتم طيبين ورمضان كريم عليكم. النهاردة معانا أستاذنا الكبير، ولي الشرف إن أنا أقدمه طبعا أستاذنا مجدي أمين، أستاذ بجامعة عين شمس في القاهرة. أهلا وسهلا بحضرتك يا دكتور.
اهلا وسهلا. اهلا وسهلا.
ازيك يا دكتور؟ اخبار حضرتك يا دكتور؟ ان
الحمد
شاء الله
لله.
الدكتور مجدي ان شاء الله يعني هيتشرف وهيدينا النهارده محاضره قيمه عن الاسبيريشن Assessment and Management. فلو حضرتك ان شاء الله يعني نستمتع بالمحاضره بتاعت حضرتك النهارده ان شاء الله يعني.
شكرا. الخير.
ان شاء الله. اتفضل يا دكتور.
انتوا كده شايفيني كويس؟
تمام يا دكتور، تمام.
السلام عليكم. أنا شاكر جدا المجهود اللي بتعملوه كلكم ويعني I'm very grateful for this opportunity to be of any help to any one of you. Many thanks to Dr. Banhawi, Dr. Rantisi, and Dr. Muhammad Salah. Very grateful for you all. Well, let me start this lecture. We want to go through this few things. There are 8 things that I want to go through. The first 4 I would want to go through quickly in the first maybe 15 or 20 minutes. And that will highlight the important physiological aspects of the swallowing, touch on how common it is, and review the disorders, etiology, and the patient's group. And then come to the clinical presentation. And I hope I would finish this by 20 minutes or so. And then I will go to the more important aspects of this lecture, the last 4 things: the investigation tools, the management consideration and how you take your decisions, and the rehabilitation of the swallowing, either by speech and language therapy or by surgical procedures. So let's start by the physiological aspects of swallowing. Now, the airway and the food channel share the same area here. And to swallow, you would have to stop the respiration. You would have to protect the nasopharynx from regurgitation of food. And you would have to pass the bolus of food within 1 second into the hypopharynx, where the upper esophageal sphincter would open up and accommodate the bolus. About 30 different muscles and certain nerves, starting from the cortex, the brain stem, the basal ganglia, peripheral nerves, all share doing this, coordinated and with very fine tuning of the pressure and the timing of all the events. The basic thing is that the soft palate would elevate to protect the nasopharynx. The upper esophageal sphincter would relax and then open, relax first. The larynx would close and go high up and anteriorly. And the tongue would press the bolus, and the pharyngeal clearance would be accomplished by the constrictor muscles. And again, I stress this should happen in close synchrony and should last only 1 second. If it remains more, particularly in patients who have higher respiratory rate, the risk of aspiration would be high. Now, if you measure this on a time scale starting from 0 to 0, this would take 1 second. Just before the pharyngeal phase starts, the glossopharyngeal, the glossopalatal and the glossopharyngeal muscles would open up to allow the food bolus to get into the aura and the hypopharynx. The nasopharynx would be shut off by the velopharyngeal junction. These events start early. You would want to start this before actually the bolus passes into the pharynx. The bolus would stay in the pharynx depending on its volume. If it's less than 1 milliliter, it wouldn't take much time. But if it's about 30 milliliter, that will be more than a big spoonful. It would take up to 0.2 seconds. The velopharyngeal junction closure would continue all through this, all through the process. Laryngeal vestibule closure would start with the bolus getting into the hypopharynx and extend until the whole of the bolus has cleared off the pharynx. The upper esophageal sphincter would remain open for the whole of the 1 second, but it would close off before laryngeal closure is finished and before nasopharyngeal closure is also finished. It's not just the timing and it's not just the synchrony, it's also the pressure in certain areas of the hypopharynx that determine whether you would have an adequate pharyngeal deglutition or if you would aspirate. Now note this, that the main pressure generation to the bolus would be the tongue base pressure. This would exceed sometimes 130 millimeters of mercury. The upper esophageal sphincter resting pressure is less than this. So in a resting position, you wouldn't expect the upper esophageal sphincter to pass all the bolus. And certainly if there is a spasm, this would overcome any pressure generated by the tongue base or generated by the pharynx. Pharyngeal pressure is actually less than the tongue base pressure. And that's why the front part of the bolus would actually reach the upper esophageal sphincter quicker than the peristaltic wave generated by the pharynx. Traditionally, the act of swallowing was subdivided into four different phases. Now that's useful to start understanding the process, but it's not what actually happens, because these four phases overlap and overlap considerably. And when things go wrong, it would affect them in different ways. So it's not very useful after the very preliminary introduction into swallowing to classify things into an oral cavity, an oral phase, an oral propulsive phase, and then a pharyngeal, and then an esophageal. It's just useful for the introduction to the understanding, but then that's about it, basically. So we'll go through this. The oral phase could last anything. It depends on how you want to chew your food. This is the enjoyable part of the deglutition. And it can remain from 3 seconds to up to 9 seconds. It can remain, it's very voluntary controlled. But the idea is to prepare the bolus by mastication and by mixing with saliva in order that it would pass quickly through the pharynx. During this stage, the palatopharyngeus and the palatoglossus and the soft palate closes off the oral cavity from the rest of the airway. And then things start to move. The tongue is moved upwards and a little bit backwards. The mandible starts to elevate, and the soft palate moves into another position in order to shut off the nasopharynx. And these three phases would happen into the transient phase during the deglutition. But this is what matters. This is how aspiration happens in this phase. These are the 6 things that should happen in less than 1 second. Now, you see here that the bolus had reached the first layer of the hypopharynx at 0.9 seconds, and it finishes up at 10 seconds. And it passes into the hypopharynx, not the nose, and not the larynx, because the larynx had closed and is elevated and pushed forward. And the peristaltic wave plus the pressure generated by the base of the tongue would push the bolus down. And if the upper esophageal sphincter is opened, then the bolus will pass into the esophagus and the pharynx will be clear from any residue. Now, remember that the upper esophageal sphincter pressure could prevent the whole event from progressing of the bolus into the esophagus, but it should relax just before the arrival of the bolus. And it doesn't open up actively, it just relaxes. And what happens is that when the larynx is moved anteriorly and superiorly, the cricoid anterior, the posterior plate just pulls on the anterior part of the pharynx and opens up the upper esophageal sphincter. And we'll see later that this differentiation between the actual relaxation of the valve and the opening is important in selecting the treatment modality. Relaxation is different from the opening and should precede it. Now, how common is aspiration? It's surprisingly common. 30% of the patients who had stroke would have aspiration, a degree of aspiration. And a considerable number of patients who have other neurological problems like Parkinson's or Alzheimer's would also suffer from dysphagia and aspiration. And in fact, most of the elderly patients who are staying in hospital would have a degree of dysphagia or aspiration as well. But the other good reason to have aspiration would be problems in the larynx or the pharynx itself rather than problems in the CNS. Now, this can be increased if you have gastroesophageal reflux. And of course, if you have tracheostomy, the chances would be about almost 2 in every 3 cases because of the laryngeal fixation and the loss of reflexes in the larynx. 2/3 of the patients who have head and neck oncology, particularly in the larynx or the pharynx, would have a degree of dysphagia or aspiration. And even if you have a general anesthetic for normal population or for other operations, there will be a significant number of patients who still have dysphagia, temporary dysphagia or aspiration for a while. These are the groups of patients who would suffer from dysphagia and present with aspiration. We've been through the neurological and neuromuscular disorders, but there are also some autoimmune disease either in the pharynx or in the esophagus that may affect this as well. But the patients that we see most are actually patients who suffer from laryngeal or pharyngeal disorders or problems in the neck, like all patients who have tumors in there or had radiotherapy or had surgery for it. And there are another group of patients who have it for different things like certain medications, ACE inhibitors, and drugs that induce xerostomia, for example, eosinophilic esophagitis, and pharyngeal pouches, a variety of other causes. But these are the causes that we see most problems in the pharynx and the larynx. So most of the patients that I've actually treated are either patients who lost the mobility of their vocal folds following thyroid surgery, or who had partial laryngeal surgery or irradiation, or who had injuries affecting the larynx and the pharynx. The same thing applies to pharyngeal disorders, particularly injuries and tumors after resection or irradiation of the pharynx, and of course paralysis of the pharyngeal muscles as well. Age is important. It's independent factor in causing aspiration. I mean, most elderly would have other conditions like other neurovascular problems, or they would be on certain medications. But age alone is an independent significant factor in causing dysphagia and causing aspiration. Lingual pressure is the #1 reason for that. When you lose a bit of the lingual pressure and control, then you start to have aspiration, followed of course with the problem affecting the oropharyngeal muscles, but also things like dryness of the mouth and slow esophageal motility or spasm, sensory changes in the pharynx, loss of muscle power and muscle volume, and medications would also contribute. Smokers can also suffer more from dysphagia and aspiration compared to non-smokers. And in some studies, this showed that most smokers would actually have a very diminished reflexive pharyngeal swallowing. And radiotherapy has acute and late changes affecting the irradiated area. So it can start first by causing edema and erythema of the mucous membrane and stiffness of the muscles and alteration of the secretions. But lately, after 6 months, they start to have fibrosis as well, and there will be damage to the blood vessels. There will be also neurological changes and reduced contraction of the muscles of the pharynx, the larynx, and the floor of the mouth. They would continue to have poorer clearing of secretions in the pharynx and reduced laryngeal closure and elevation for a good while. And sometimes even up to 10 or 20 years, they would come presenting with dysphagia because of webs and because of strictures So that's an issue that will have to be considered. Radiation to the pharynx is not risk-free. And of course, any problem in the chest can also contribute to this, because if you have a very rapid respiratory rate, then the chances of the bolus clearing through the hypopharynx in less than a second is reduced. And the same applies if you have a reduced lung capacity or maximum inspiratory lung capacity. So it's almost a routine now that you measure the pulmonary function in every patient who present with aspiration. And you also measure their oxygen saturation. But we move to other factors, like factors in the tongue itself, reduced pressure or reduced volume of the tongue, but more importantly, reduced ability to control the timing, the very fine tuning of the timing of the base of the tongue movement in relation to other movements of the pharyngeal phase of swallowing. As I say, you would have general causes for aspiration, including the age and the smoking and the irradiation and respiratory problems, but you also have organ-specific disorders. And we'll come to this later, because there are two ways of understanding the physiology and also assessing the patients. One of them is the traditional oral phase, oral transient, hypopharyngeal phase, and esophageal. And the other is this, organ-specific disorders in aspiration. It have its applications not only in the assessment, but also in the choice of the treatment. You would want to really specify what went wrong with the swallowing. Is it the tongue, either its mobility or its bulk, or the pressure generated by the base of the tongue, or if there is any problem affecting the movements of the hyoid and the larynx and the neck, because these extralaryngeal forces have a very significant effect. The larynx does not just adduct and abduct, it also moves upwards and downwards and forwards and backwards. So the extralaryngeal forces, and in conjunction with the hyoid and other muscles in the neck, are important in the understanding of aspiration. And of course, you have the intrinsic laryngeal defects like loss of sensation and the loss of motor power and glottic incompetence. And the same applies to the hypopharyngeal defects. So we'll take a few seconds to go through this. The hyoid factors, the main thing is that the hyoid should move forward and upwards during the pharyngeal phase of deglutition. If it doesn't, then it's difficult for the upper esophageal sphincter, the cricopharyngeal sphincter, to open up, even if it is relaxed. The actual movement of the larynx away from the hypopharynx is what opens up this cricopharyngeal sphincter. So if you have a reduced range of movement, then it would affect the way you swallow things. And of course, if you have a weak muscles in the neck because you have had previous surgery, even hyoid surgery, if you remove some of the strap muscles, or certainly if you had a partial laryngectomy operation entailing extensive resection and dissection in the neck, affecting not only the muscles but also its innervations, then this would affect the way the larynx moves in relation to other structures in the neck. The intrinsic laryngeal factors are obviously very important, because you would need to have an adequate glottic closure to prevent aspiration. And if you have a paralyzed vocal fold, then chances of aspiration are obvious. And of course, if you have bilateral vocal fold paralysis, then you almost always aspirate. But you also can have a reduced sensation in the larynx and reduced mobility of the larynx, or just a reduced duration of laryngeal closure. You could have weak muscles in the larynx that is not efficient enough to keep the glottic closed while the bolus is passing during that important second in the hypopharynx. And there are other factors in the hypopharynx, including sensory impairment or ineffective or incoordinated pharyngeal actions, spasm in some of the muscles, particularly the cricopharyngeus, and that would be reflected in some inefficient swallowing, and some of the bolus would stay around, hanging either in the vallecula or the pili fossa or just on the posterior pharyngeal wall. So that's the main thing about the physiological aspects and how common it is, and the causes of disturbance of the act of swallowing and aspiration. Now, if you want to pursue a very detailed examination and assessment of patients with swallowing, it may be a good idea if you could set up an MDT for swallowing disorders. And by this, and having other specialists involved, like gastroenterologists and neurologists and dietitian, you could actually pull up some of the cases and do a good analysis and select the most appropriate treatment. And you probably do it every second week or so. And if you see about 10 cases, and then you end up in a year seeing about 200, half of them will be new cases and half of them will be review cases. And then you could start your own practice in treating dysphagia and aspiration. They present with the usual head and neck symptoms of dysphagia and painful swallowing, and of course aspiration, choking and coughing and throat clearing. These are the classic symptoms that we all know about. I think this is important, the change in the eating habits. If you direct question, if you ask them, have they stopped eating anything because they can no longer manage to swallow, or have they changed the way they eat, they take more time, or they refrain from eating with others, refrain from going upwards for a meal, then you can start identifying the problem there. And there are a few tests that you can do in the clinic or bedside to sort of evaluate what is going on. And the easiest, of course, is asking them to swallow about 30 milliliters of water. And most patients would have no difficulty in doing this, but if they aspirate, then you know that there is something significantly wrong in their pharyngeal or laryngeal control over swallowing. And you can do it for patients who have tracheostomy by mixing a little bit of a dye or having a colored drink. And if you see it trickling from the tracheostomy tube, then you know that they had aspirated. And of course, you could auscultate the neck for any residual bolus and measure their oxygen tension. But it's really this that will bring you closer to the diagnosis. Investigations of these patients would clarify things and generate much more information about what is going on. These are the commonest things that we use, the fees, and we'll go through this in a second. Sometimes you can combine it with sensory stimulation by using the tip of the scope to measure the sensation of certain areas in the pharynx or the larynx, or even puff of air through the scope, and video fluoroscopy. But sometimes you would need to get a barium swallow, particularly for things like pharyngeal pouches, or if you suspect lower esophageal problems. Rigid endoscopy is rarely required in functional problems. If there is a if you suspect things like tumors or webs or pouches or things, rigid endoscopy may be resorted to in a later stage. And of course, now you can do a complete esophagoscopy through the nasal examination by using a thin fiber optic endoscopy as well. Now, you may need to have a CT scan or an MRI scan in case of tumors, in case of excessive scarring. Ultrasound scan can give you a very useful information. It's dynamic and it entails no irradiation, and we'll go through this as well. But also there are other tests like manometry, in which you could actually measure pressures in certain spots at certain timing. and muscle potential if you are suspecting a paralysis or weakness of some groups of the muscles. So let's go through this. The first thing, of course, is what you do, and the first time you see the patient, you do a flexible laryngoscopy, and it gives you a very good amount of information about the glottic closure and the way the larynx, whether the larynx is sensitive or not. And it would also show if there is any residue in the piriform fossae or if there is any mucosal lesion. So that's the preliminary thing. You just do a flexible endoscopy of the larynx and the hypopharynx. But of course, if you would want to combine this with swallowing a colored material, then you get more information, because you could see at the end of the initial swallow whether there is any residue, the piriform fossa in this case, and some residue in the vallecula as well. You could see if there is any aspiration during swallowing. The problem with FEES, of course, is that you don't actually see the act of swallowing itself, because the muscles collapse on the tip of the scoop. But you see the after effect of it. You see how much is left in the pharynx and whether there has been any spillover or not. This is the gold standard for the examination, assessment of the aspiration, video fluoroscopy, and it shows you the bolus when it's moving, and it shows you the movement of the different segments, the tongue, the mandible, the soft palate, the way the larynx moves, the way the hypopharynx bolus propagates, and whether the upper esophageal sphincter opens up or not. It doesn't give you much information about pressure, of course. This is left to things like manometry. But if you can see the bolus propagating in and the expected time frame, then you know that things should not be too far from normal. But if you need specific information about whether the muscle here is contracting because of spasm or because of fibrosis or because the larynx is different reasons for muscles not opening or not working well, then you need to measure the pressure inside, and that's left for manometry. Now, to quantify your video fluoroscopic findings, there are several proposed schemes for this. This is perhaps the commonest, the penetration aspiration scale. And basically, it's one, if everything is fine, then you are fine. There isn't anything abnormal here. And the worst scenario is that the material does not only passes through the larynx and below the glottis, but also the patient is not coughing. There is no effort at coughing. And it's helpful, this scheme, because milder cases in which there's some material goes into the glottis, but you still can effectively clear this out by a good cough. And even if you cannot clear it out completely, but you still show some effort, these patients usually respond well with speech and language therapy rather than surgical intervention. Whereas the higher grades, 5 and 6, you probably have to think of surgical intervention of some sort. There is another way of quantifying your video fluoroscopic findings. Rather than look into the aspiration, the degree of the material passing into the larynx and down the glottis into the trachea, you would concentrate on the residue, how much residue is left around. And again, number one is that there is no residue. Within a second, the whole of the dyed bolus should clear from the hypopharynx. And the worst scenario is when you have residue in 3 areas, in vallecula and the posterior pharyngeal wall and the piriform fossa. But if you have only a little bit in the vallecula, that's a smile. If you have it in the vallecula plus one other site, either posterior pharyngeal wall or piriform fossa, you go through the grading system. And again, it is useful in decision making and choosing the best possible treatment. So I'll give you a few examples of how the how the video fluoroscopy can be useful. You could see here that the patient is able to swallow things, but then there is a delay here. The bolus just doesn't pass quickly through the upper esophageal bit. This is the cricopharyngeal spasm in here. And that's one of the commonest causes of having dysphagia and aspiration afterwards. Another example is when you have limited mobility of the larynx in relation to other structures in the neck. In order to have an effective swallowing, the larynx should go up and should go forward. Now, interestingly, most mammals have their larynx very high up in their neck. And in fact, most of the mammals and humans under the age of 6 months have their larynx quite close to their soft palate. The epiglottis is very close to the soft palate. It's when the larynx goes down in mankind, probably to have better voice, that problems like aspiration started to show up. But if you have limited movement of the larynx, then you can see the dye is going through the glottis into the trachea. And one more example about delayed or incomplete pharyngeal emptying. Again, if after swallowing you are left with that amount of dye staying in the hypopharynx, you're not sure whether this is due to cricopharyngeus sphincter spasm or due to the very weak propulsive action of the pharyngeal muscles. And that's when other tests come into play. If you want to measure the pressure of the cricopharyngeus, or if you want to measure the pressure of the pharyngeal muscles in order to determine whether Cricopharyngeus Myotomy is, for example, useful or would not. So you use these classifications or grading system to quantify the findings from the video fluoroscopy. Now, if you do the two most common things in an aspirating or a dysphagic patient, if you do a video fluoroscopy and you do a video endoscopy with a dye like a fees, then you usually get a good amount, but not absolute agreement between the two. You would still need to look through other things sometimes, get further tests, but you would expect a fairly good amount of agreement between the two things. Now, there are other things that you can use, not instruments, just tools like questionnaires and grading system, so that you could classify patients into mild, moderate, and severe. And that would have its effect on the choice of treatment, as I will go through quickly later. This is the tool that I personally use. Manometry comes into this. There will be few cases in which you actually need to measure the pressure of the cricopharyngeus sphincter and the pressure of the pharyngeal muscles before selecting treatment. And if you remember the slide I'd shown earlier, the pressure of the bolus at the very beginning of the pharyngeal phase is mostly generated by the tongue base thrusts, and it would reach about 130. But the pressure of the muscles, of the cricopharyngeus muscle, if it's in this area, then you know that there is a spasm of the muscle, that it has not relaxed. If it does relax, it would be closer to almost 1/3 this amount of pressure. So this is where manometry is useful. Now, you can sometimes combine the two together. You can use fluoroscopy and manometry at the same time. Sophisticated software and sophisticated machines can do this and can bring you a very detailed information about this. I'll show you one example or two. But the main advantage of combining the measurement of the pressure and the way the bolus passes through the hypopharynx is that you can time it better. You can see the relationship between a bolus obstruction and pressure generation, things like this. Now, this is one tool that's not being used enough yet. This is used selectively in some centers, but it has very good advantages. And I think this may be actually the future because it's dynamic and non-invasive, and it gives you the actual movements of the floor of the mouth and the tongue and the hyoid and the larynx and the pharynx during various maneuvers. You could ask them to swallow, you could ask them to phonate, and you could ask them to breathe. You don't need contrast because water would be would have a different sonographic properties than air. It's cost effective. You could use it in the intensive care. You could use it in different settings, and it's cost effective related to other techniques. And you use the usual probe, the 2 megahertz probe that you use for thyroid evaluation or neck evaluation. It will give you good information about how the larynx closes, and sometimes it can also, and you can also do it not only in the axial plane, you can have it in the sagittal plane, and you could get a good amount of information just by using this machine. But of course, it is the amount of information will be proportional very much to whoever is doing the examination itself. So this is how you would assess the patient and try to categorize them. Not only mild, moderate, and severe, but also you would need to clarify very precisely what is the problem. Using not the old scheme of oral and oral transient and pharyngeal, but using the functional oriented scheme of, is it a tongue-based problem? Is it a soft palate problem? Is it a laryngeal closure problem? Is it a laryngeal elevation problem? Pharyngeal muscle problem? Cricopharyngeus, things like this, and sensation problem. And if you reach that stage, and sometimes you may not every patient you can actually diagnose and analyze fully, but then you start the management. And some of the management is non-surgical. And of course, this is what you start with in most cases. You can start the easy things by time. You can modify the diet. You've seen from the test that which diet is giving them more problems. Is it fluids? Is it solids? Is it dry food? Is it big boluses? Things like this. And you try to modify the diet accordingly. And if the patient, of course, is aspirating heavily and developing chest infection, you could instruct nil by mouth for a while to buy time. You could use feeding tubes, at least temporarily. And you could revise the medication, see what sort of medications they are taking, and some of the hypertensive treatments and some of other treatment that causes xerostomia can actually increase the dysphagia and increase the aspiration. You could try things like proton pump inhibitors or antacids if the patient has a significant history of gastroesophageal reflux. So all these are simple measures. The main thing about the non-surgical management is rehabilitation of the swallowing, and we'll go through 10 different things that you can use to rehabilitate this patient. And usually gives a good response. I mean, most of the patients who have dysphagia would be treated by this. You only have to operate on patients who fail this or patients who have a life-threatening aspiration. Tracheostomy is a different thing. Tracheostomy is, you get sometimes asked to do tracheostomy because the patient is aspirating and have a chest infection. And the problem with tracheostomy, it doesn't help with the swallowing. In fact, it is one of the commonest causes for swallowing problems. We'll go through this in a second. So swallowing rehabilitation would entail one of these few things. The easiest, of course, is try to stimulate the pharynx and the base of the tongue and the oropharyngeal sphincters to work by things like very cold sips or carbonated beverages, for example. Sometimes pressing with a very cold spoon can all help with the regaining some of the stimulation and inducing normal swallowing. But it's this, the muscular rehabilitation, that most of the speech and language therapy spend time with patients doing. I mean, the vast majority of patients are treating by this, trying to improve their muscle performance and trying to strengthen some muscles and trying to improve the coordination, starting from the jaws and the lips and the tongue base and the larynx, either closure or elevation and things like that. This is the bulk of the speech and language therapy work with dysphagia. There are other ways of, at least other experimental ways of trying to rehabilitate swallowing, and this include skill training, and we'll go through this in a second. So this is how you'd want to improve the sensory perception by a variety of things. You would want to have thermal stimulation, sometimes tactile stimulation by applying pressure or having cold or carbonated beverages. But as I say, it's the muscular improvement that is the bulk of the work they do. This is the video fluoroscopy with manometry combined. This is very useful in the analysis and also in predicting outcome for these patients. And most speech and language therapy, if they have access to this, would use it at the beginning of their program and at the end or through it as well. It usually takes about 8 weeks of retraining to get some response. And you do various things to improve specific disorders. You could do at least almost a dozen of different things to improve. But you need to specify first what is wrong before trying to improve this. One of the things you do is this is very easy, chin to chest maneuver. And it's helpful in certain problems. It improves the contact of the tongue with the posterior pharyngeal wall. If you put your head closer to your chest, it opens up the vallecula as well, so accommodate a little bit more of the bolus and prevent aspiration. And if there is a delay in swallowing reflex, it improves. One of the common things you can use, particularly after irradiation or after a partial laryngeal resection, is head rotation techniques, in which you would ask the patient to swallow and their head is rotated to one side or the other. And if they have it rotated to one side, then they can have the bolus going through the other one easier. So if you have a problem with the right piriform fossa, for example, you turn to the right side and improve the passage of the bolus through the left. You can also extend the head backwards, and that would help with the nasopharyngeal closure, and also help if you have a weak floor of the muscle actions. Or you could try the shaker exercise, in which you ask the patient to lie flat and try to raise his head above the level of the shoulders, keeping the rest of the body flat. And this is a good exercise to the floor of the mouth muscles that works by improving the excursion of the larynx and the hyoid and the neck, so that it open up easier the upper esophageal sphincter. Supraglottic swallow is again very common, very easy to do. You take a deep inspiration and then swallow, and then cough and then swallow and then inspire again. And it improves the glottic closure and also improves the supraglottic defensive mechanism. You could try to improve the whole of the muscles involved in the swallowing by effortful swallow. If you swallow hard, if you try and swallow hard on anything, you just ask your muscles to do a little bit more than they usually do. And hopefully their muscles will work better and have more strength. And It improves generally most of the other muscles of the pharynx, but particularly it is useful in laryngeal glottic incompetence. There are certain maneuvers. One of them is Mendelssohn's. Mendelssohn has devised this maneuver in which if you have a slow or a weak movement of the larynx and the neck, doesn't move upwards and forwards easily, you could try actually to simulate the action digitally. And by doing this, you hope that the muscles are going to work better doing this. And this obviously opens up the cricopharyngeus muscle. Masuku maneuver is when you try to hold your tongue forward as much as you can, but comfortably through your open teeth. Hold it there, and if you pull your tongue forward enough, then you increase the bulge of the posterior pharyngeal wall and improves the pressure generated by the tongue base on the posterior pharyngeal wall. You could try to improve your chest muscles, the expiratory chest muscles, by expirating into a spring valved apparatus, and you could change the pressure in the valve to allow a gradual improvement. And by doing this, you clear your chest and the upper airway better. It also improves the floor of the mouth muscles. So all these head extension, head rotation, and chin tilt, and all this can improve specific groups of muscles and make your swallowing function better and prevent some aspiration. And I say most of the patients would actually be, most of the milder cases, I should say, would actually be helped by this and would not need further intervention. There is another strategy to deal with this, which is don't give the patient the easy way of feeding, like give him the food that he can only swallow. Or no, you would actually want to retrain the brain itself to acquire new skills, particularly in patients who had strokes, for example, or patients who have other neurological problems. You retrain the brain to work through challenges by gradual challenges, of course. You change the texture, you change the amount of the bolus and things gradually. And by doing this, you hope to improve the function of the muscles. And you can, of course, stimulate the brain itself either by magnetic fields or electric fields, or stimulate the muscles. That's the other way of trying to do that. All these are very experimental. Now come to the main thing here is that, all right, you've seen the patient, you analyzed the problem, and you come to the point of having to decide what you should be doing for him. Now, if you have not identified precisely what is wrong, then you cannot go much further. You would need to have this very clear. What is wrong? Is it the laryngeal closure, the floor of the mouth movement, the base of the lung? One single or two or three, but very specific causes for the problem. And you would try first all the conservative rehabilitation, but of course you would have to weigh this against the time and the limits, because if the patient is aspirating heavily, you don't have much time to try other things. You may have to interfere earlier. You would consider carefully whether the procedure you're doing is temporary, like, for example, injecting things into the vocal folds, or permanent solution in the form of thyroplasty or permanent injection of the vocal cords, whether the procedure is reversible, like laryngeal suspension, or permanent. And these procedures, the temporary procedures, have the advantage that you can try them first, and if they work, then you can use to the more definitive treatment. Remember that a good amount of these patients you're going to operate on for aspiration may require revision surgery or another type of operation if the first operation fails. You may try to buy time using things like pegs or even tracheostomy sometimes if you are forced to because of a very bad chest condition. But the more drastic operation of laryngeal shunts and laryngeal pexes and even laryngectomy should be your last resort. You should have tried everything else before you come to this point. So these tracheostomies and pegs are things that you do to buy time. Most of the patients you would treat would require one of these three things. I'm not going through the pharyngeal pouch surgery for this lecture, but it's laryngeal competence procedures, Cricopharyngeus Myotomy, and laryngeal suspension. Most of the patients you will treat would be one of these procedures. But then if it's a severe degree of aspiration or life-threatening, you may have to consider doing more drastic procedures like laryngoplasties, in which you close up most of the larynx or separate the larynx from the airway, from the pharynx, or even remove the whole of the larynx itself. As I say, tracheostomy is not good for your swallowing, and most of the patient would continue to aspirate or start aspirating if they have not. And because of the different reasons, the cuffed tubes will press on the esophagus. You will have reduced glottic reflexes, ineffective cough, and decreased laryngeal elevation because you have the trachea fixed by the tracheostomy tube. But you sometimes have to do it just to buy time, as I say, if you have a very bad chest condition for a patient. Cricopharyngeal dysfunction is common. And some reports is up to 25% of all the patients you're going to see with dysphagia and aspiration will have a degree of cricopharyngeus sphincter disorder. And it's easy to treat, provided that you know that this is the exact problem with the patient, and there are too many other problems, then these are the patient that gives the best result. And the easier thing, of course, is to inject Botox in there, and you inject it in 3 sites, midline and a little bit posterolateral to that, and it works quickly, but it's temporary. And if it's successful, you can repeat it. And if you want a permanent solution, you can do the myotomy endoscopically by using a laser, or you can use an external route and split the muscle. When do you actually need to do this? Is probably the commonest procedure you'll be doing. It's in the milder and the moderate forms of laryngeal penetration. The aspiration should be a post-swallow, not during or not pre to swallowing. And you should make sure that there is good hyoid and laryngeal mobility, because if there isn't, there is no much benefit in doing a myotomy. If the larynx is not moving, the upper esophageal sphincter is not going to open up. And you shouldn't be using it for generalized dysphagia if you have more than 1 or 2 defects. If you have several defects in the base of the tongue and the palate and the pharyngeal wall and things, then surgery, conservative surgery like this doesn't usually work. Success rates and the published varies between 100% for very lucky surgeons and 20% for more realistic ones. These are the reports of different things. I think it should be somewhere around 65 to maybe 70 or so success rate. My own experience is that if you do it for patients without, if you're not too selective about what you do, then you get almost just 60% resolution, 40% either just improved or not improved. But when we analyze why we have not, these patients have not improved, these are the patients who have limited hyoid or laryngeal mobility, or they have multiple pharyngeal defects, or they have aspiration that is pre-swallow. And if you are, we went through these phases, and we are very selective now about the patients whom we offer a cricopharyngeal myotomy, and you achieve better, but not 100% control if you are sure about the mobility of the larynx and the tongue base pressure and mobility, and if there is only 1 or 2 pharyngeal defects, not multiple or generalized defects. The other common procedure that you would do for aspiration would involve the larynx. And of course, you have tried first voice therapy and things. But if there is incompetent glottis or incompetent movement of parts of the larynx, you start to think about vocal fold injection and medialization procedures, either thyroplasties or by injection. Well, most cases you would need to consider arytenoid rotation because most of the aspiration happens in the posterior part of the larynx. This is by far the wider part of the glottis. The glottis is like a triangle, and the posterior half is 7 times more than the anterior half in surface area. So this is when you would benefit from arytenoid rotation. There are also other things that you can do in the larynx, like you try to approximate the level of the cricoid of the thyroid, and it's very easy procedure you do. If you have opened up the neck to do a thyroplasty, just entails putting a suture around the inferior thyroid horn, passing around the cricoid, and it improves the glottic closure and stretches the larynx a bit. But you have to do laryngoplasty if you cannot stop the aspiration by the more conservative ways. We'll go through this. So arytenoid adduction is when you have a large posterior gap or the levels of the vocal cords are not equal. You've tried thyroplasty type 1 and it didn't prevent the aspiration. Or if you have a cricoarytenoid that's fixed, it's not moving, or after extensive laryngeal trauma. And the idea is simple, is that if you can move the muscular process of the arytenoid forward and laterally, then you move the arytenoid in such a way as to bring the maximum possible adduction of the vocal cord. The vocal cord attached to the vocal process would move in there. Now, how to get to the muscular process of the arytenoid is fiddly, because you get from the outside and pass through certain structure. It's a bit fiddly, this type of operation. The landmarks is this: the muscular process is where the posterior cricoarytenoid and the lateral cricoarytenoid comes end to end. You can make a small window in the thyroid area, level of the vocal fold or around the level of the vocal fold, and try to find your way to identify the muscular process. And it's usually not very difficult. If you have about a 1 centimeter window in the right place, then you can reach by dissection into the laryngeal muscles, and you can see the fibers of the thyroarytenoides and the lateral cricoarytenoids fibers change directions, and then you can identify the muscular process easier. Now remember that the thyroid cartilage posterior third is actually a pharyngeal part rather than the laryngeal. If you get in there, then you would find yourself in the perform fossa. So you'd have to work in front of the oblique line of the thyroid, and certainly just around the level of the vocal fold, not higher, and not in order to get the muscular process of the arytenoid. And it's about 5 millimeters deep from where you make your thyroid window. This is the cricothyroid plication operation I was telling you about, and it's easy. What you need is to, if you have your suture around the inferior thyroid horn, just pull it around the cricoid, and by doing this, you close the cricothyroid visor and you stretch the vocal cords and the vocal folds and adduct them further. If these operations didn't work, then you start thinking about up the ladder with things more drastic. One of the things you can do is try and allow anteroposterior collapse of the airway by removing most of the posterior part of the cricoid cartilage. You still leave a sleeve of the cartilage here so that the arytenoids can still work on top of it. But by doing this, you approximate you reduce the dimensions of the subglottic space and perhaps improve the swallowing and prevent aspiration. I'm not very fond of this type of operation. Never worked with me. You can also use stents to prevent spillover and allow breathing through a tracheostomy tube. Again, one operation that's hardly used nowadays. But if you've tried the simple things and you're still not able to stop the aspiration, or if you have severe aspiration from the very beginning, the larynx is not moving, the larynx is not closing, perhaps the larynx had stopped the sensation, and there are several segments involved, and they are very weak in coordination, there is significant risk to develop aspiration pneumonia and life. It's here that you start to think about the other groups of operations, including separating the larynx and the trachea from the pharynx, suspending the larynx, closing up of the larynx, or even removing the larynx altogether. The easiest of them is this, suspending the larynx. This is if you have a larynx that doesn't move well in the neck, and the neck doesn't raise up and doesn't project superiorly. You could suspend it to the mandible, and that's the initial operation, the initial description, suspend the thyroid cartilage to either the hyoid or the mandible. But the other thing you can do is remove the upper half of the thyroid cartilage. And if you do this, then it's easier to suspend the remaining part of the thyroid to the hyoid, and the hyoid to the mandible. And it does help this time. And the advantage that it's reversible, almost reversible, because once you take off these sutures, then the larynx could, if you need to, the larynx would restore to the normal position again. There are other ways, again, possibly reversible, in which you would do a tracheostomy, and you would close up the proximal part of the trachea. You just close up, but that will leave a sump in here, and secretions would collect in here, and you get infections, and you have very bad healing. And I think most people had stopped doing this because it's not very rewarding. You can do it in another way. You could take the upper part and get it out of the skin laterally. So you have two openings, one into the larynx and one into the lung. Again, if for any reason you want to reverse this procedure, you almost certainly will get a tracheal stenosis at the level of the anastomosis. So it's not something that most people would do. Now, the larynx is not working well. There's reduced sensation or inefficient coordination or whatever. And you don't want to lose the whole of the larynx. You don't want to remove it, but you want to close it up. Just allow a little bit of opening in it, so which you can speak, but you would breathe through a tracheostomy tube. You can close the larynx either horizontally, like the pillars, or vertically, like the pillar, or horizontally by putting the epiglottis closer to the, rather than closing it vertically, you can close it horizontally. But it's the same idea. You close up the larynx, save a very small opening through which you can actually have a voice. Now, up till here, I think most patients would benefit from one or two operations of what I've just described. In my entire career, I've not seen a case. I've seen only one single case of laryngectomy for aspiration, and it wasn't done by me. It was done by someone else, one of my colleagues. But for me, I think the end of the road thing would be the Biller's operation, for example, trying to close up most of the larynx. One other group of aspiration would follow partial laryngectomy patients, and there are very good reasons to have aspiration after partial laryngectomy, including change in the position of the cricoid ring in relation to the hyoid, and decreased mobility of these structures of these laryngeal nerves or the superior, either the sensation or the motor parts are affected. If you have disturbed relation between the epiglottis and the cricoid, or the cricoid itself may be partially resected and you have one arytenoid higher than the other. If you have a smaller amount of mucosa to cover the raw surface and end up having scar tissue and granulation tissue, or if you have scarring in the periform fossa. It's very common to have a degree of dysphagia and aspiration after partial laryngectomy. I'm very thankful to Professor Kaki, who actually taught us all how to do a very effective partial laryngeal surgery. He insisted on having a good periform fossa size on the two sides. He also tried to preserve the innervation of the larynx, including the superior laryngeal and external branches of it. Preserve as much as you can, at least one mobile. You need at least one mobile arytenoid. You need good mucosal cover to all structures, because if you don't do this, scar tissue are going to form, and fibrosis would change the position of all your reconstruction. And you need the residual parts of the larynx to be working and to have enough sensations. You need to preserve the nerves to all these muscles, and of course, you need a good Cricopharyngeus Myotomy at the end of the operation. By this, I finish the presentation. Thank you very much for listening. I'm happy to take all your questions.
Hello, our Professor Magdi. Hello. Hello.
Hello.
Thanks
Hello?
for your nice lecture, our professor.
Thank you very much.
Thank you. So, excuse me, our colleagues, Dr. Magdi will take a break for praying, Azan al-Maghrib, UK time. So 5 minutes, and we will return back again. Okay.
Very well. Okay. Thank you very much.
So, our colleagues, if you have any questions regarding the lecture, please write it in a comment. Hello.
Hello, come back. Yeah.
Welcome back again, our professor.
Thank you.
So we will begin with the questions. That's first question.
Yes, being asked to review a patient who developed aspiration following tracheostomy and ventilated for COVID, how to assess the patient, especially if he's still testing positive, what is the step? Yes, I mean, flexible nasal endoscopy is aerosol generating, of course, and this is the last thing you want to do if the patient has got has a COVID positive state. I think if a patient had reached the stage of having a tracheostomy and is being treated in an intensive care, the best way from here is to try to feed him either through a nasogastric tube or a PEG. I don't think that you will gain much from subjecting yourself and your colleagues to risks of aerosol generating procedure. You know that COVID is not going to clear quickly from someone who had reached the stage of a tracheostomy. And on balance, I would think it would be risky to proceed from here. Try and buy time by either a nasogastric tube or a PEG until it's clear what's going to happen to this patient, basically. Yes, I mean, persistent throat pain in young adults is not usually infective. I mean, you could swab this pharynx several times and you hardly grow anything but commensals. The three very common reasons for persistent sore throat in young adults will be smoking, mouth breathing, and reflux. And these are the three factors that would give you something similar. And of course, you can have neuralgic pain sometimes, but most of the patients who I've seen with persistent sore throat would have one of these three things. They are either mouth breather because of nasal deformity or nasal obstruction, or they have significant reflux, or they are smoker or have other sources of irritation to their pharynx, like manual workers in dusty atmospheres or things like this. Yeah, a barium swallow would tell you something about the structural problems. Like if you have a pouch, for example, a barium swallow would show it. If you have a stricture or a web, a barium swallow would show it. Of course, if there's any risk of aspiration, you would use graphene rather than barium. But this type of test does not, even the modified barium swallow test, does not give you much more information apart from structural abnormalities. And the vast majority of the patients you would see with aspiration would have functional problems. They will still have a larynx that moves, a tongue base that moves. They will not have much in terms of structural abnormalities as much as loss of incoordination, weak pressure generation, incompetent closure, things that are much better evaluated by video fluoroscopy. And if you have access to video fluoroscopy, then my advice, of course, is don't hesitate. This is the gold standard. If you don't, the second best will be the modified barium swallow. Sometimes it can tell you something about. Remember that you don't want to. The question you want to answer is not whether the patient is aspirating or not, because you can answer this question by other simpler tests like fees, for example. What you want to answer by using video fluoroscopy is what exactly is the problem here, at what level, to what degree, and how you can help this patient further, or which surgery and which rehabilitation technique you want to use. Yeah. No, it's not the same. We're not. Aspiration is a collective term for the whole thing. If you have a certain amount of the bolus getting into the larynx above the vocal cords that can be ejected, then you grade this into 6 different things, 6 different grades. If it penetrates below the vocal cords and gets into the trachea, and particularly if you don't have enough good cough reflex, then you have the full aspiration, where you can have various degrees of penetration just to the laryngeal interoitus level, or just above the vocal folds level, or penetration just below the vocal cords level that you can cough up. And they are all different grades of aspiration. Yeah, after laryngectomy, you can get dysphagia, but usually don't get aspiration, of course, because you've removed most of the larynx, unless you're referring to partial laryngectomy, of course. But if you do the standard laryngectomy, then you have the airway separated from the pharynx. And sometimes you can have fistulas, sometimes you can have a leak from the new pharynx into the remaining part of the trachea, then you could have aspiration. But most of the times you can have just difficulty in swallowing rather than aspiration from after total laryngectomy. And that's if you don't have enough pharyngeal mucosa left behind, or if the patient had been irradiated, or if the resection is extensive and removed most of the pharyngeal plexus around the new pharynx reconfiguration, or if the patient is using a cuffed tracheostomy tube. Various things could give difficulty in swallowing after total laryngectomy. After partial laryngectomy is different, because you still have a functioning laryngeal residue here that has limited in its mobility, limited in its the amount of the structures after resection. And this is where you see most of the aspiration, the post-laryngectomy aspiration. And in the last 2 slides, I've tried to show that if you still have a good mobility of at least one cricoarytenoid joint, a stable cricoid, a good and adequate pharyngeal pathway in the form of 2 piform fossae, and intact and preserved laryngeal and pharyngeal sensation and motor activity by trying to preserve the nerves to the larynx and the pharynx, good coverage of the bare surfaces of the cartilage with mucous membranes or with grafts or flaps. This would decrease the amount of aspiration you get, but of course you would need to retrain these patients to swallow again with the limited capacity after partial laryngeal surgery. No, I'm not neglected phoniatricians. I've used a different term. I've used the speech and language therapist. I'm sorry for this, but it's no. What I was saying is that the bulk of the treatment for these patients are done by the speech and language therapist department, the phoniatrician, as you prefer to say, who would share in the analysis itself, the video fluoroscopy and the fees, and will also do all or most of the rehabilitation of the swallowing, all the procedures that I've referred to, from head extension and chin and head rotation and tilting and supraglottic swallowing. All these are done with the done by phoniatrician / speech and language therapy department. I'm sorry, I've used a different term. I'm referring to the same thing you mean. It's only when all these things fail, then we start to think about surgery. But they certainly start by allowing them to try and improve the swallowing and the aspiration of the patient for a good amount of time. Of course, if they are aspirating heavily and there are risks to the life or developing pneumonia, you may have to interfere earlier. Otherwise, it's at least 8 to 12 weeks before you consider any intervention. Yeah. Yeah, if you go frame by frame during the video fluoroscopy, you would see what exactly is happening, not just to the bolus itself. I mean, if you focus on the bolus, you will miss very important information going around it. What is happening to the other structures when the bolus is moving? So you could see the bolus moving first, and if it spills into the larynx, when there isn't any other attempts of the pharynx to pharyngeal movements otherwise, or even laryngeal elevation or laryngeal of hyoid excursion, then you have grounds to think that this is a pre-swallow type of aspiration. If you have done a FEES assessment with sensory stimulation prior to the video fluoroscopy, you would have gained some insight about how sensitive is the pharynx and how ready is it to trigger the swallowing reflex and the chain of events that happen after swallowing. A video fluoroscopy combined with a FEES would probably answer the question most cases because you would know something about the sensation of the supraglottic and the glottis and the base of the tongue and other pharyngeal structures, and you could also trace the what other structures of the larynx and the pharynx are doing while the bolus is propagating. Yes, again, you would follow the same order of things. The two commonest things that you would use would be the endoscopic assessment and the video fluoroscopic assessment. And if you have doubt about the pressure generated by the base of the tongue, then perhaps you would need also manometry to tell you that the base of the tongue had generated the required 130 millimeters of mercury that is usually within the normal range to start the bolus propagation. So you examine the tongue for any fasciculations, for any mobility problems initially, and you'll see it moving, and you'll see the full range of the tongue movement during the initial examination and the flexible endoscopy. And you may notice any gross deformity with the mobility of the tongue, and you will see it moving during the video fluoroscopy as well. And if it doesn't move well, and if it doesn't reach where it should reach to generate to the palate in order to start generating the pressure, then you suspect that there is a problem with the tongue base, and in that case, a manometry would provide you the ultimate answer. Yes, and I mean you would need to clarify why they had such a severe pharyngeal residue. Is it because the pharynx cannot generate enough pressure to clear, or is it because the upper esophageal sphincter, the cricopharyngeal sphincter, is not opening up timely to allow the passage of the bolus? or is it because there is defective sensation? There are various reasons why you end up having a large residue in the hypopharynx after swallowing. And now you would consider the risks of this on the aspiration on the lung conditions, and whether you have enough time to retrain this patient other maneuvers to clear this or not. If there isn't, you may be pushed to intervene earlier. But if you can actually have time, then you start the speech and language / phoniatric works with this. It's usually a combination of inability to open up and defective muscle contraction, either from the base of the tongue or from the rest of the pharyngeal musculature, the three constrictors. And generally, you can try the speech and language therapists will try the things like their programs for maybe 8 to 12 weeks and see if you could actually help with this. And if not, then it's surgery, I'm afraid. Provided, of course, that they have enough chest capacity to withstand 12 weeks, 8 to 12 weeks of trying conservative management. Yes. What I was trying to say is that you've got to answer two questions at the end of your assessment. What is wrong exactly? And if what is wrong is that the larynx is not functioning well because it has been irradiated, it's full of scar tissue, it's lost a part of its sensation, it lost a part of its mobility, it lost a part of its glottic closure, and the other question is how severe is the aspiration, and if it is mild or moderate, you may try to rehabilitate this larynx first. You may try to consider the reversible things. You could actually do thyroplasty bilaterally. You could inject the larynx, the vocal folds, in order to improve adequacy of closure. And you could try and stimulate the larynx to, you could try and suspend it. You could do a Cricopharyngeus Myotomy. But if your question is about someone who has intractable, like if you've tried everything else and it's not helping, then I think you're left with the ultimate solution for this, which is a laryngectomy, particularly if this patient has already been irradiated. You don't want to do things like laryngoplasties in an irradiated cases. I think the reasonable thing here would be to do a laryngectomy. It would be a shame to do a laryngectomy for a larynx that's been free from the tumor. But if it's not functioning well, then there isn't much else that you can do. Now that varies. I think if you are waiting for things to happen, like this COVID-19 patients, for example, you're not sure about his survival and about what is going to happen to him over the next maybe 6 to 8 weeks or so. And I think that the least that you can do is give him, if he is aspirating heavily, then give him nasogastric tube. Most patients would tolerate it well for 2 or 3 weeks, for example. After that, I think you would better start to think about a PEG tube, which gives a better way of feeding this patient. So basically, you are just buying time for things to develop in one direction or the other. The answer to the question is, what are you waiting for? Are you putting the nasogastric tube because the patient had trauma and you're expecting him to recover after a certain amount of time, or if he's got a COVID that you're not sure what's his survival after another few weeks. If it's something temporary, you can keep the nasogastric tube. But if there's permanent dysphagia or aspiration, you better go up the ladder, think about other things. If the patient is very frail, then the answer is a PEG tube. If he can tolerate surgery and other forms of intervention, then that's what you should be doing. But perhaps the answer to your question is 2-3 weeks or so. Yes. If you go back to the presentation, this is one of the two things that you rely on heavily in order to assess the patient. It answers a good amount of your question about what exactly is wrong and how bad is the condition. If you could see the dye passing through the larynx without a cough reflex, you know that this is the same information you get from video fluoroscopy grade 6, for example. If you can see that the larynx is not, there is no reflex glottic adduction on touching of the foot to the or the tip of the scope to the larynx, you know that there is something wrong with the sensory, with the sensation of the larynx. If you see a residue in certain piriform fossae or the valleculae, you can try these with different food textures. You can try it with fluids and semi-solids and even biscuits and things like harder things, and you could see if there is a problem with one particular consistency of the food or the other. So it's one of the two things that you rely on to get most of the information, the whole of the batch, this plus the video fluoroscopy. And there will be other things, as I mentioned, like manometry and if you need CT scans or ultrasounds and things like that. But the bulk of the information you will get from FEES and from the video fluoroscopy. Yes, and I mean there's a best answer to different questions. Most of the patients I have operated on for dysphagia or aspiration were actually either patients who have tumors in the larynx or the pharynx, or patients who had focal fold pulses after thyroidectomy, and maybe less than a third or less than half of the cases are patients who have presented primarily with dysphagia and aspiration due to various other reasons. The best possible combination in my experience would be in the patients who present with a primary problem of dysphagia and aspiration would be a Cricopharyngeus Myotomy combined with either a thyroplasty or arytenoid rotation, perhaps combined with cricothyroid plication, and in few cases combined with laryngeal suspension. That will give you possibly the highest possible success rate. If it is, if the aspiration is due to partial laryngectomy or injuries or post-radiation, then you probably need something more drastic. You need to think about laryngeal pexis and laryngoplasties. And as I say, I've not done laryngectomy for that yet, but I know of only one case that couldn't respond to anything else. Depends on the general condition, of course. I mean, if the patient had an acute CVA, then you would need to start first with rehabilitation. You're not going to operate on him soon. So depends on his general conditions. If he is able to take the video fluoroscopy test, if he is able to take a FEES test, then you can assess what is wrong and start with the early things. That usually takes a good few weeks before you would actually ask to intervene. Until then, the main worry is what is happening with his central nervous system. And that's when most patients would have the temporary things like the nasogastric tube or having a PEG. I get asked from time to time to do a tracheostomy to these patients, and I feel bad. I always try to argue that it's not going to help. You can only do it if you are forced to do it, if there is a bad chest condition and you want it to help with the aspiration of the chest. So I think by the time they are able to recover partially from their CVA and have the assessment test, the 2 assessment tests, is when you start considering which type of intervention you would want to start with. Oh, thank you very much. Thank you very much for your listening.
Thanks for you again, Professor Magdy, and thanks for your time with us. So I will mention your account Facebook on the video to answer any question in the comments through Facebook video.
Very well. Yeah, very well.
So
thanks very much for your help.
And we hope to do another lectures with us also.
Thank you very much. Yes, always happy to be of any help. Thank you very much. Thank you.
Thank you.
Thank you.
Bye-bye.
Bye-bye.